Lindsay Roberts, and today I will be sharing with you some literature on the late-term effects of radiation therapy for pediatric patients. Upon completion of this presentation, you should be able to explain the effects of ionizing radiation on the body, identify the late effects of radiation therapy for head and neck cancer, identify the late effects for brain tumors, identify the late effects for Wilms tumor, identify the late effects for Hodgkin's disease, and lastly, recognize the correlation between high-dose radiation therapy and second malignant neoplasms. How many people here know someone who has been affected by cancer? Did they undergo radiation therapy during their treatment? Are you aware of the effects that radiation can have on the body? Most of us are aware that too much ionizing radiation can have ill effects on the body. These effects can be even more damaging in children as their cells are still growing and dividing. According to an article by Malika Ashford, ionizing radiation weakens and breaks up DNA, either damaging cells enough to kill them or causing them to mutate in ways that may eventually lead to cancer. This is why radiation therapy is such a successful treatment for cancer patients. It is able to kill and or break up the cancer cells in a specific area. This is also why radiation therapy has late effects, such as genetic mutations and other cancers. Here's a picture that illustrates how much radiation the average person receives each year. As you can see, almost half of the radiation comes from background sources such as radon, internal, space, and terrestrial. Medical radiation does account for much of the dose, especially if a person has a serious medical issue that requires constant imaging procedures. And the bulk of this comes from computed tomography, which a lot of us are familiar with, and a lot of us know that has a really high dose. X-rays were first discovered in 1895 by Wilhelm Conrad Röntgen. It wasn't long after this that radiation was used as a form of treatment for certain diseases, such as cancer. The first radiation treatment was done by Emil Hermann Grube on a patient with breast cancer just 1 year after the discovery of X-rays in 1896. Because no one had an idea of the biological effects radiation had on the body at the time, the treatment was considered to have poor outcomes compared to the side effects that it produced. It wasn't until the late 1920s that physicians discovered it was better to break up the radiation dose into smaller sessions than to have one large exposure. This picture was taken in 1967 at the Radiation Science Division of the United Kingdom's National Physical Laboratory. This picture shows a 2-year-old boy, the first patient to receive radiation therapy from the Medical Linear Accelerator at Stanford University in 1956. This patient suffered from a tumor in his eye, but with radiation therapy he was able to regain full sight for the rest of his life. I have broken the research up that I am sharing with you into 5 categories: radiation therapy for the head and neck, radiation therapy for Hodgkin's disease, radiation therapy for brain tumors, Wilms tumor, and second malignant neoplasms as a result of radiotherapy. These are all commonly found cancers in the pediatric population. I will present the audience with statistics these studies have shown, such as late-term effects, age range and median age, radiation dose, fraction sizes, and overall functionality of these patients at the time of treatment. Like all treatments, radiotherapy is indicated when the chance for cure is high, although any exposure to repeated radiation carries the risk of both acute and long-term side effects. Radiation therapy is one of the most common and effective treatments for children with head and neck cancer. These malignancies include rhabdomyosarcoma, which is cancer of the tissues such as muscle, tendons, or bone, retinoblastoma, cancer of the retina in the eye, and tumors of the nasopharynx or nose. One study gathered information on a total of 17 patients that had survived megavoltage radiotherapy treatment for head and neck rhabdomyosarcoma between the years of 1967 and 1994. The group consisted of 6 females and 11 males, with a median age of 5.7 years at the time of radiotherapy was administered. The study states the tumor locations as the following: orbit in 6 patients, infratemporal fossa in 4, paranasal sinuses in 2, and supraglottic larynx in 2 patients. The patients received the radiation treatment either at the site of the primary tumor or tumor bed, the tumor in the whole brain, or the tumor in the cranial-spinal axis. There was a median dose to the primary site of 5,040 centigrays and 3,000 centigrays to the whole brain. All but one tumor were treated with 150 to 200 centigray fractions. The other patient received 250 centigray fractions for a tumor that was located in the larynx. As you can see here, CGY stands for centigray, which is a unit of absorbed dose used to measure exposure to the patient. Every single patient treated with radiotherapy experienced some kind of long-term effect. Of the multiple lead effects observed, by far the most common included facial asymmetry, visual and orbital issues, and dysfunction of the neuroendocrine system. Many factors affect the degree, progression, and irreversibility of the condition, such as the dose, irradiated field, what type of tissue is being exposed, the age at which the patient is diagnosed, and how well the epithelial cells are able to heal themselves. According to an article titled Factors Influencing Radiation Effects, there are physical factors such as the type of radiation and dose, chemical factors such as what type of particle molecules are present at the time of exposure, biological factors such as the organ sensitivity to radiation, and technical factors such as how the radiation was delivered. These all play a role in how the body will respond to mass amounts of ionizing radiation. Here I have a picture of different tissues and the radiosensitivity of these tissues. As you can see, bone marrow is very highly radiosensitive, whereas the central nervous system is the least radiosensitive. One study made it clear that the occurrence of second neoplastic malignancies is directly related to treatment involving radiation. Bhatia et al. Stated that treatment with radiation therapy at a young age for Hodgkin's disease was a risk for solid tumors. Hodgkin's disease is cancer of the lymph nodes, and the most common subsequent malignancy from radiotherapy was breast cancer. 42 total cases of breast cancer were observed because of the radiation-based treatment, with an average time development of 18.1 years from the initial diagnosis of Hodgkin's disease. These patients were found to have a 56.7-fold increased chance of developing breast cancer. Malignancies such as thyroid cancer, bone tumors, colorectal cancer, lung cancer, and gastric cancer were also observed in this set of patients. Among the 1,380 patients treated for childhood Hodgkin's disease between 1955 and 1986, the estimated cumulative incidence of subsequent neoplasms was 26.3% at 30 years after diagnosis of Hodgkin's disease, according to Bhatia et al. This provides proof that these patients have an increased risk of varying cancers following their radiotherapy treatment for Hodgkin's disease. Radiotherapy has come quite a long way over the years and has the ability to radiate the area of malignancy with great accuracy and precision while limiting the radiation to surrounding tissues. This new form of radiotherapy is called ISRT, or involved site radiotherapy. With ISRT, it is easier to aim the radiation at only the site that needs treated, in this case the lymph nodes that consist of Hodgkin's disease, and also to any nearby areas the cancer has spread to. Doctors carefully calculate dose in order to reduce acute and long-term effects, and the radiation is aimed at only the area in need of treatment. The use of ISRT helps decrease or eliminate the amount of radiation the surrounding healthy tissues receive. This technology could be a step closer to reducing the long-term effects of radiation therapy treatment in pediatric patients. As you can see here, I have different exposures of the radiotherapy. Right here, the last one is involved site radiotherapy, and as you can see, based on the gray boxes that are highlighted, involved site radiotherapy is the smallest. 2 studies were reviewed that concerned the treatment of brain tumors such as low-grade glioma with radiotherapy in pediatric patients. One specifically focused on 78 patients diagnosed with low-grade glioma with a mean age of 9.7 years, receiving 54 grays of conformal radiation therapy, or CRT. The tumors were located in the diencephalon, cerebral hemisphere and cerebellum, and deficiencies in cognition, endocrine function, and hearing were observed. This article stressed that conformal radiation therapy for young patients should be delayed if at all possible, as the younger the patients were, the more late-term effects of radiation they experienced. According to Merchant et al., the effect of age exceeded that of radiation dose. Patients younger than 5 years experienced the greatest decline in cognition. The patients underwent cognitive tests before and after their treatment to assess the effect CRT had on cognitive function. This cognitive test evaluated their intellectual function, memory, social-emotional adjustment, academic skills, and adaptive functioning for up to 5 years after treatment. Growth hormone deficiency is of great concern when conformal radiation therapy of the brain is performed. Many patients undergo growth hormone replacement therapy. One article addressed the effectiveness of this therapy as well as late effects of CRT. A total of 65 survived children were studied from the years 1985 to 1987 after receiving radiation therapy for brain tumors. Follow-up exams were done to determine bone age, as well as an analysis of different hormone levels such as thyroid-stimulating hormone, thyroxine, and somatomedin C. It was found that 26 of the total 65 patients studied developed growth hormone failure, and 8 of those 26 were hypothyroid. Growth hormone failure was twice as common after focal infratentorial and craniospinal radiation therapy when chemotherapy was also involved, meaning the use of chemotherapy increased the risk of developing growth hormone deficiency. This seems to be a trend between all of the articles reviewed. The combination of chemotherapy and radiation therapy increases the incidence of long-term effects from radiation. Nephroblastoma, also known as Wilms tumor, is the most common kidney cancer found in children. According to the article titled Treating Wilms Tumor, radiation therapy paired with surgery and chemotherapy is the most promising treatment for nephroblastoma. Many studies have evaluated the late effects of radiation therapy in patients diagnosed with nephroblastoma at a young age. One study evaluated 42 patients after megavoltage radiotherapy was used to treat their tumor. The study consisted of 25 females and 17 male patients, with a median age of 48 months at the time of diagnosis. Hemi-abdomen radiotherapy was given to 36 patients, while whole abdomen radiotherapy was given to 6 patients. The patients were broken into 3 groups based on the amount of radiation they received. Group A received 1,000 to 1,200 centigrays. Group B received 1,201 to 2,399 centigrays, and Group C received 2,400 to 3,000 centigrays. All patients received chemotherapy as well. The study showed that 13 out of the 42 total patients experienced no late effects at all. By far the most common late effect found was scoliosis. The statistics show that the occurrence and severity of the scoliosis was directly related to receiving a higher dose of radiation during their treatment. Other musculoskeletal abnormalities that were common included muscular hypoplasia and iliac wing hypoplasia. These late effects were also shown to be more severe in patients who received a higher dose. A total of 4 patients developed benign neoplasms, 3 were in the direct field of radiation, and 1 was outside of the field. 3 second malignancies occurred: chronic myelogenous leukemia at 9 years after initial diagnosis, osteosarcoma at 11 years after diagnosis, and breast cancer at 25 years after diagnosis. Another study done at the University Hospital of Münster in Germany evaluated patients that had abdominal radiotherapy for Wilms tumor or Hodgkin's disease and focused on the late effects of the liver, kidneys, and bowel. According to Bowling et al., when all methods of follow-up examination were used, abnormal results were found in 78% of the cases after radiotherapy to the right lobe, but only 50% of cases after radiotherapy to the left lobe of the liver. The data, once again, showed that the severity of the late effects was directly related to a higher dose, as 86% of these cases received greater than 35 grays during their treatment. Bowling et al. Also stated that the extent of liver damage was associated with the amount of liver volume exposed to ionizing radiation and also the dose delivered. Despite the evidence from these studies, an accurate dose-response relationship has not been established for radiotherapy of the abdomen. Although a dose effect and volume effect have been established as radiation doses less than 20 grays to major parts of the liver or higher doses to smaller parts seem to be safe in children and adolescents. This area of study is an ongoing process, as late-term effects take decades to evaluate, and they are just now on the brink of new findings. As I stated in the beginning of this presentation, ionizing radiation either kills cells or mutates them, which can lead to other cancers. This is why second malignant neoplasms are one of the most common late effects of radiation therapy, especially in pediatric patients. Since 1972, the Late Effects Study Group has been conducting studies on patients who developed second malignant neoplasms, or SMNs, as a result of radiotherapy. The initial malignant neoplasms include many of those that have been discussed, such as Wilms tumor, retinoblastoma, and Hodgkin's disease, with the latter 2 being the most common. The study showed that about 68% of second malignant neoplasms developed in tissue that was irradiated. The most frequent occurring second malignant neoplasm were bone sarcomas, closely followed by soft tissue sarcomas, thyroid carcinomas, and carcinomas of the breast and skin. According to Meadows et al., most of the second malignant neoplasms were related to radiation, which is widely known to cause cell mutation. The late effects of radiotherapy are to be expected, as high doses of ionizing radiation will have ill effects on the human body. These studies show that the higher dose received during treatment, the more severe the late-term effects will be. There are a few trends that have developed as researchers continue to analyze data, specifically that the late effects developed depend on the primary malignancy that is found, the area of tissue that is irradiated, and the method that is used to deliver the radiation, such as CRT, ISRT, megavoltage radiotherapy, etc. That concludes my presentation on the late-term effects of radiation therapy for pediatric patients. Thank you so much for listening, and if you have any questions, please list them below.